Good morning, everybody. First of all, let me thank KSOS and Dr. Samyukta for giving me this opportunity. Today, I would be discussing about the disorders of accommodation. With an increase in demand for the near vision task associated with today's modern lifestyle and around with the COVID pandemic, the disorders of accommodation have now become the new pandemic. So which are the patients in whom we have to suspect disorders of accommodation? We suspect such conditions in patients with no significant refractive error and no significant phoria, but presenting to you with complaints of eye strain, including discomfort and strain associated with near task, blurred near vision, fatigue associated with near task, and difficulty with attention and concentration while reading. So in these patients, we do a battery of tests for accommodation, which was discussed in detail by Dr. Samyukta, which includes the assessment of near point of accommodation, the normal accommodative response assessment by using the MEM retinoscopy, the relative accommodation assessment, and the accommodative facility testing. So, first we test for the tests which require the stimulation of accommodation, like using the minus lenses, and if they are affected, that means the patient has accommodative insufficiency. If the test probing the ability to relax the accommodation, especially using the plus lenses, are problematic, then we have to think in terms of accommodative excess. And if both the tests, those that require the stimulation of accommodation as well as the relaxation of accommodation, are affected, then it is accommodative infacility. So broadly, the disorders of accommodation can be classified into 4 categories. The first one being accommodative insufficiency, the second one is ill-sustained accommodation, you have accommodative excess and accommodative infacility. Now coming to the first one, that is accommodative insufficiency, it is a condition where the patient has difficulty in stimulating the accommodation. It can also be called as premature presbyopia, and latent hyperopia and overcorrected myopia can present with eye strain. Before we jump into the NSBVA management, we need to rule out certain mimickers which can present with accommodative insufficiency, especially drugs like alcohol, cycloplegics, antihistamines. There are a group of diseases in adults and children which can produce accommodative insufficiency, and keep a watch on neurophthalmic conditions, which can also cause these problems. So that definitely need to be ruled out before we go into the definitive test for these. For accommodative insufficiency, the definitive sign would be a reduced amplitude of accommodation. As she had well described, you check it with the near point of accommodation assessment with the RF rule, and you convert it into the amplitudes. And if it is 2 diopters less than the Hofstadter's minimum amplitude, which is calculated as 15 minus 0.25 into age, then it is accommodative insufficiency. And the patient also has difficulty in clearing -2 with monocular and binocular accommodative facility testing, and when you check for the accommodative response, there is a high MEM retinoscopy findings. The complementary signs would include a low positive relative accommodation and a high negative relative accommodation. Ill-sustained accommodation actually is a subclassification of accommodative insufficiency. It can also be termed as accommodative fatigue, where when you check for the accommodative amplitude, it will be normal in the beginning, but when you go on checking, you find that there is a deterioration in the accommodative amplitude. So repeat measurements of accommodative amplitude is mandatory for the diagnosis of ill-sustained accommodation. Now, how do we go about the treatment of these 2 conditions? Basically, if there is any emmetropia, optical correction of emmetropia should be done, and that should be followed by added lens power therapy. And then you go into vision therapy, which can be either in the office-based or a home-based. Now, what is the amount of the plus lens that you need to prescribe for these patients? There are 2 options. Either you can take the arithmetic average of the positive and negative relative accommodation and prescribe that, or the second option is you can do the accommodative response assessment, that is the MEM retinoscopy, and from that value you can subtract the normal value of 0.5 and you can give the classes. Vision therapy has basically 3 steps. The first one is to normalize the accommodative amplitude. The second one is to incorporate the speed and response into accommodation responses, and the third one is to integrate it. The third type of accommodative problem is accommodative infacility, and in this case the patient has difficulty in shifting focus from distance to near. So it is the amplitude will be normal in this particular condition, but the problem is with the dynamics of accommodation, that is the latency and speed of accommodation would be abnormal. The symptoms, in addition to the usual eye strain problems, the patient will have difficulty changing the focus from distance to near and from near to distance. In this particular case also, it is mandatory that you rule out certain mimickers which can produce accommodative insufficiency in facility, like drugs, some general diseases like anemia, diabetes, encephalitis in adults, anemia, mumps and measles in children, and neurophthalmic cases. Once they have been ruled out, you have to confirm this by ensuring that the patient has difficulty in clearing both plus and minus lenses by using the accommodative flippers. So the definitive sign is difficulty in clearing -2 and +2 with monocular accommodative facility testing, and complementary signs would include a low negative relative accommodation and positive relative accommodation, and difficulty clearing minus and plus with binocular testing also. And a secondary fusional problem can also be associated. The treatment of accommodative infacility would be vision therapy. Now we come to the fourth and the final one, that is accommodative excess. In this particular condition, the accommodative response exceeds the accommodative stimulus. An uncorrected refractive error and hyperopia can sometimes precipitate this, and ciliary spasm sometimes causes increase in myopia, that is called pseudomyopia. Sometimes a dramatic presentation with intermittent attacks of accommodative convergence and meiosis can occur, that is called spasm of the near reflex. In this particular case also, you see that there are a group of systemic conditions which can mimic this, and they need to be definitely ruled out before you go into the definitive diagnosis. So the definitive signs in this particular condition are the variable visual acuity findings, variable static retinoscopy and subjective refraction, and when you do the accommodative response assessment by using the MEM retinoscopy, you find that there is a low value of MEM retinoscopy, and the patient has difficulty with plus lenses when you are testing the accommodative facility. The complementary signs would be difficulty clearing plus with binocular accommodative facility, reduced negative relative accommodation, reduced negative fusional divergences, and esophoria and myotic pupil. The treatment is by using vision therapy. So what are the vision therapy options available? You can have the common ones which are very familiar, like this is a heart chart where the patient has to look at a near target and then a distant target intermittently so as to stimulate and relax the accommodation. Accommodative flippers, which were used for diagnostic purpose, can also be used for therapeutic purpose for stimulating accommodation and relaxing them. The other tests would include a red rock test, accommodative rock cards, accommodative hoping cards, loose lens rock. So these are the specific tests which can be done for the accommodative problems. Now to sum up, in accommodative insufficiency, patient has difficulty clearing minus lenses, and treatment is added lens power and vision therapy. In infacility, the patient has difficulty with minus and plus lenses, and treatment is vision therapy. And in accommodative excess, the patient has difficulty with plus lenses, and the treatment is vision therapy. Thank you for your patient listening. Thank you.
Thank you very much, Divya, for that wonderful session. Now inviting Dr. Ashwati P to have her session on convergence anomalies.
Good morning all. Thank you KSOS and Dr. Samyukta for this wonderful opportunity. My topic today will be disorders of vergence. The classification of vergence disorder is actually a modification of the original Duane's classification by Vick, and this is based mainly on two variables. One is the AC by A ratio and the other one is the distance phoria. So accordingly, we have three major classes: those with low AC by A ratio, those with normal AC by A ratio, those with high AC by A ratio, and each of them is further subdivided into three based on the distance phoria. In addition to these horizontal heterophoria, we also have vertical anomalies. The patients of vergence anomalies usually present with esthrombic symptoms, and that would be more significant during prolonged near work like reading.